Okay, so today what we're going to do is go over undifferentiated abdominal pain. Hopefully this lecture is useful for you, particularly when you get out into the real world and start working up abdominal pain. So without further ado, let's get into the PowerPoint here. Okay, so fairly short lecture, but really something to help you kind of get into the real world. You're going to be working up undifferentiated abdominal pain. It's probably the #1 presenting complaint. The caveat here is this is non-female abdominal pain. So abdominal pain is a very vexing, wide topic. However, female abdominal pain encounters a lot of other organs that won't be addressed in this abdominal lecture. So what's the chief complaint and how are they presenting? So who's good at abdominal pain? Well, traditionally we feel like the surgeons should be the best at undifferentiated abdominal pain, which they are extremely well. However, we are going to probably, if we're an emergency room provider, be the person that is filtering these patients to the surgeons. So in reality, the emergency room providers are probably the #1 provider that's going to assess undifferentiated acute abdominal pain. The surgeons usually have already, the patient has already been evaluated and filtered to them for the most part. So we want to go through our normal OPQRST. When did it start? What makes it worse? What makes it better? How severe is it? And then the timing of either flares or how long the pain lasts. Is it associated with anything? So we really dive into the history here. We want to look at the patient. How does that patient look to you? This is where you get that gestalt of sick, not sick. So, does the patient writhe around in the stretcher? Are they laying perfectly still? Are their knees flexed up to their chest? So these are all things that we can observe. You can also just, with a kind of clinical gestalt, after you get to doing it for a while, just look in the room and go, okay. The 25-year-old with his knees flexed up to his stomach that's been vomiting and drives by you in the stretcher, you can look at him and say, yeah, that's a nappy. So as we start our conversation with this patient, we should just, kind of ask an open-ended question. What brings you in today? You can always give a patient one chance at answering an open-ended question. And if they go bing, bing, bing in a million different directions, then you can guide them in. Then we go through systematically through our OPQRST. The OPQRST is really, whatever heck mnemonic you want to use, but just make sure that you're getting all the high points. When did it start? What brings on the pain? Is it associated with PO intake? Is it associated with urination? What's the quality? Is it a cramping? Is it a colicky? Is it a stabbing pain? Does it go anywhere else away from the location of the pain? How severe is the pain? And then does it come and go? Is it staying there the whole time? Is there any change to it? And then associated signs and symptoms. So is it associated with nausea and vomiting? Is it associated with dysuria, vaginal bleeding, back pain, fever? Any of those things are all going to help kind of strengthen our case and start to winnow our differentials. So as we continue the history here, are they able to tolerate PO food and fluid? This is a very important question, particularly with pediatrics, but really everybody. And then are the signs and symptoms worse or better with food intake? And so that kind of tells us where in that gastrointestinal tract might we find this problem. A really good medical surgical history is important. This also kind of guides us toward some other differentials that may be lingering here. A surgical abdomen is always a risk for bowel obstruction because there's more scar tissue in there. The bowel can peristalse on itself, causing an obstruction. So once we get through with that, we're going to start our exam. You really want to start kind of gingerly away from the patient's pain. So you don't just want to dive into their most painful portion and start pushing on them. They will hate you for one, and it will not give you a very good exam. So you want to go from the least painful location. You want to start with some light bowel sounds and then slowly kind of press down. Sometimes I'll press with my stethoscope in a position, particularly with like a pediatric, if I want to assess for appendicitis and I know that they're going to jump around no matter where I push. I'll push lightly and then more firmly with my stethoscope right over the appendix, which is in the right lower quadrant. So we also want to assess bowel sounds, the most painful location. We'll start superficial and work our way in. Their hydration status or CVA tenderness, those things should all be documented and assessed. Where does it hurt, right? So you can ask the patient to take one finger and place that finger exactly on the pain. Because if you say, where does it hurt? They're going to say, from my chin to my pelvis. But if you ask them to take one finger and put it directly on the pain or the spot that hurts the most, that's generally where they will point. There's actually been studies that show that people are pretty good at self-assessment. And then do not neglect a testicular exam, all right? So a lot of providers have been burned by abdominal pain. And what it is it's really referral pain. So make sure that you do a good testicular exam and check the inguinal canal. There's been many testicular torsions that have been missed and the patient loses their testicle and the doctor gets sued, or the provider gets sued, and it's just bad juju. So always make sure that you think that there is an option of a testicular torsion. That always needs to be in your differential, particularly obviously with male patient. All right, so all these signs, right? You've got sign after sign after sign, but what do they all mean? So you've got rebound, right? So what's a rebound? Basically, rebound is you press on the abdomen, and when you let go, the pain gets worse. Guarding, any type of guarding, there's different types of guarding, right? There's voluntary, involuntary guarding. Involuntary guarding is more worrisome. Peritoneal signs, so anything that jiggles the peritoneum can cause pain in the abdomen. That is a peritoneal sign. So sometimes that's board-like stiffness. Sometimes that means they're walking crunched over, but some sign that causes pain when the abdomen is jiggled. A psoas sign, the psoas is this muscle that runs right in front up into the lower abdomen. Well, when you extend that hip and pull back, it's going to pull that musculature right over the top of the appendix. And so if you elicit pain with that, as the hip flexor glides over the appendix, then that's a positive psoas sign. The Rosvig sign is when you press on the left quadrant or the left lower quadrant and it causes pain to the right lower quadrant. That's a normal Rosvig sign, or I guess that sign is abnormal, but that's a Rosvig sign. A reverse Rosvig's is associated with diverticulitis, and you're actually pushing on the right quadrant and eliciting pain on the left. Murphy's sign, so that sign is right upper quadrant pain, but it is specifically written for that sign that they take a deep breath, and as they're inhaling, you're tracking up that right upper quadrant, right up under the rib cage there, and as they're inhaling, they'll stop because it hurts so bad. And then your McBurney's point tenderness is one of those signs that we do for an appendicitis. So appendicitis actually has three signs. You have the psoas sign, the Rosvig sign, and the McBurney point. So those are all good signs that you can do. You can also have a kid like jump on his right foot, run in place. Those are all things that would cause the peritoneum to be jiggled and would cause pain, probably in the right lower quadrant when elicited. So what's the diff? Well, we've got a huge amount of differentials here, right? There's definitely more causes of abdominal pain than we can even list here. However, there's some that we have to be really good at working up. And these are as follows: appendicitis, cholecystitis, pancreatitis, diverticulitis, bowel obstruction, bowel perforation, mesenteric ischemia, kidney stone, gastritis, gastroenteritis, and a triple A. So we really need to elicit which ones can kill you the fastest and the deadest. The definitely is the triple A. Triple A is usually found in older vasculopaths with abdominal pain and is identified with a bedside ultrasound. So what's a vasculopath? Well, it's just this cute little nickname that we've given to these people that are prone to throwing clots. So who is a vasculopath? Well, a vasculopath would be somebody with poorly controlled lipid profile, hypertriglyceridemia, or some sort of hyperlipidemia, who has AFib, who has atherosclerosis. All those are all reasons that they're going to throw a clot, so that would make them a vasculopath. Or maybe somebody with factor V Leiden deficiency, that would be a vasculopath. So these are people that make clots and throw clots, and we're suspicious of that. All right, so now we get to our workup. We want to know why we're doing labs. We don't just want to say, oh, let's get the abdominal pain labs. Okay, so we'll talk about why we do certain labs after this. With females, we always want to assume that they're pregnant. So from 2 to 99, everybody gets a pregnancy test. They are pregnant until proven otherwise. The workup, generally there might be like a workup per your the place that you're working. The hospital might have a protocol. They might have an abdominal pain workup, but normally an abdominal pain workup looks like this. It's a urinalysis, an HCG with females, CBC, CMP, which is your basic chemistries plus your LFTs. Coags, sometimes they'll have a BMP and then they'll do the LFTs, which is your liver function test, separate. A VBG, which is a venous blood gas, and a lactic acid. So those are all kind of popular tests. So what do they mean? Well, the CBC is going to screen for anemia. It's a really good screening tool. You're also going to see your red blood cell indices. You're going to see your white blood cell count. So we're really worried about the white blood cell count when we're talking about appendicitis. It is really something that we need to know, that 30% of appendicitis will present with no elevated white blood cell count. So let me say that again. 30% of appendicitis, acute appendicitis, will present with no white blood cell count. So that's why we really have to keep our mind together. And when we're suspecting this, we don't want to give up on it until they're seen by a surgeon. Another thing that might be elevated with an appendicitis or in any acute inflammation is going to be a CRP. So that's a C-reactive protein. It's considered an acute phase reactant. CRP is elevated in times of inflammation and infection. So that's another pertinent test. Usually, if you read up on appendicitis, you'll see that they'll cite CRP levels with white blood cell count, and then definitely your clinical gestalt. CMP, so that's all your chemistries plus LFTs. So you've got electrolytes, renal function, which is your creatinine, BUN, and then liver function. So we really want to watch these, right? What's their electrolyte? That could be a risk for bowel obstruction. Hyperkalemia or hypokalemia can cause muscular problems, which can cause an obstruction. We want to look at renal function. Is there any pre-renal, post-renal, or intrarenal damage? Is there elevated BUN? Is there creatinine off? Do we have an AKI accompanying this abdominal pain? And then liver function, right? So definitely if we're suspecting some sort of badness in the right upper quadrant, we're going to check LFTs. So that's going to give us an AST, ALT, and an ALP. And those we can use to kind of elicit exactly where our discomfort is. Plus, if we're working up the right upper quadrant, we'd want to also do a lipase. Coags, so these are mostly for pre-op stuff, right? We need to know that they can make a clot. Also, if somebody has, or we're suspecting liver disease, we want to check coags. The first thing to change when somebody has a liver that's not functioning properly are their coags. So they don't make coagulation factors because the coagulation factors are made in the liver, and then they don't clot normally. So we want to check coags on anybody with suspected liver disease. Another thing that will be off too with liver disease is their total protein. So the two first things that change in liver disease is the total protein as well as the coags. So coags is always a good test, particularly if we're worried about liver disease or the patient bleeding to death. LFTs, so great for cholecystitis, great for pancreatitis, great for any of the itises for sure. So we want to make sure that there's no liver inflammation. I know that we're not really going into female abdominal pain today, but there's one kind of rare condition that can cause liver inflammation in females, particularly if they have PID. Anybody know what that one is? So in the presence of PID, which is pelvic inflammatory disease, there is something called Fitzhugh-Curtis, which causes inflammation of the liver as well. So so that's what your LFTs are going to screen for. You can have a transaminitis with a fatty liver disease. You can also see elevations with a stone or biliary tract obstruction. Lipase, so this is the most specific test for pancreatitis. A lot of times you won't see amylase. Some panels will have both, but we don't really use amylase anymore. It's not very specific because it's not specific to the pancreas like lipase, and it elevates quicker and can titer off on you. So we like the lipase the best. Venous blood gas. So this really is looking for their status, you know, what's their CO2 status, what's the pH, and then what's the lactate. So when I've got an older individual I'm worried about just real badness in general, the lactic acid is a good indicator. This can indicate infectious process. It can indicate sepsis, and it also can indicate mesenteric ischemia. So mesenteric ischemia is where you get one of these vasculopaths that throw a little clot into their bowel. So into the mesentery, which is that kind of meshwork of fat and tissue that holds the bowel. Well, if you get a clot in there, then the bowel won't be perfused with blood, and that causes buildup of lactic acid because you're not getting blood, and so you're doing fermentation, you're building up your lactic acid stores, and that will spike in the blood. So mesenteric ischemia is one of these things that we don't want to miss in old people. It's really deadly. All right. So pain control. Now, if we're talking about abdominal pain, we should also talk about pain control. So one thing that we want to do for these people, especially if we're sure that this is an abdominal problem, we would really like to control their pain. It's better for patient outcomes in the long run. It also gives you a better physical exam after they're kind of comfortable. So usually we use narcotics in these cases. They're easy to titrate. If we frequently titrate the dosing, we'll get them out of pain very easily. A good there's so many different medications, right? So there's morphine, there's Dilaudid, there's fentanyl, all these. I think that you need to just be comfortable with one, especially if you're giving an oral presentation or trying to treat a patient and you're talking to your attending. So morphine's really easy. It's dosed at 0.1 milligrams per kilogram, which if you're talking about a 70 to 80 pound male or average individual, if you will. That's about 7 to 8 milligrams, which actually seems like a lot. I normally won't give 7 or 8. I mean, 10 would be like one of Dilaudid. So usually I start with about 4. Now, one thing that you really want to make sure, if you're giving 4 milligrams of morphine, you want to make sure that you give them Zofran, because they'll vomit on you or on your nurse or on the floor. So anywhere from 4 to 8 milligrams IV Zofran with that. So I usually do like 4 and 8. So 4 of morphine, 8 of Zofran, life is good. Don't forget, when you're giving opioids, especially in frequent titratable doses, you can cause the person to quit breathing. I showed up at work one day, walking down the aisle, still had my bag on, and looked into room 12, and there was a blue man sitting on the bed, not breathing. And I ran in there and called a code, and we got him back. He had been given his 3rd dose of Dilaudid, not by myself, but by someone else, and had gone into respiratory arrest and nobody knew it. So luckily I happened to just be walking by at the same time, and I had no idea what was going on. We just Narcaned him, and bam, he was awake. So anyway, 3 milligrams of Dilaudid prior to your CT is too much. It will make you blue. So anyway, just be particularly smart about that side effect. I'd say once you're in morphine, you're looking at least 10 milligrams, but everybody's affected differently, so make sure you watch your patient. All right, so imaging. We kind of talked a little bit. I guess we didn't talk about imaging. Well, imaging continued. I guess we kind of touched it. So imaging. Imaging by quadrant, really. So in the left upper quadrant, what are the things that it could be? Most likely a small bowel obstruction or some referral pain. Rarely we're going to need imaging here unless we're thinking about a small bowel obstruction, and then it's going to be a non-contrast CT or a contrast CT with PO contrast, which will show us where the small bowel obstruction is. If we're talking about epigastric pain, right? So we'd be concerned about pancreatitis or some atypical cholecystitis, also gastroenteritis or gastritis. An ultrasound of the right upper quadrant to rule out a gallstone or some sort of biliary tree obstruction. In the right upper quadrant, we're going to do this ultrasound, right? If we're looking for the right lower quadrant and we're concerned about appendicitis, the test of choice is a non-contrast CT. Some organizations and radiologists will want IV contrast and even PO contrast. So just talk to your radiology department. But this can be diagnosed with a non-contrast CT. If we're talking about suprapubic abdominal pain, we're usually thinking about a UTI, or in a male's case, this could be a prostatitis. Left lower quadrant pain, we're concerned about diverticulitis. That would be a CT with contrast because we're worried about infection. So this imaging stuff gets really, really cumbersome. But I think the easiest way is, if you're worried about flow, then you can do an ultrasound or a Doppler. If you're worried about infection, you need to do a contrast CT. And if you just don't know what the hell you're doing, then do a regular CT. Okay, so left lower quadrant, we have diverticulitis, contrasted CT. If they've got flank pain, we're concerned about stones. So the stone protocol is a special type of CT if you're really concerned about stone and nothing else, which normally I don't do because I want to catch other things. But there is a special stone protocol that you can do. We don't want to use contrast with stones. Why don't we want to use contrast with stones? The reason we don't want to use contrast is because it can block some of the stones. You won't see them. So it's a non-contrast CT for stones. And know this, of note, 30% of patients with a kidney stone will not have hematuria. So I've seen a lot of providers say, well, it can't be a stone, there's no blood in the urine. Well, 30% of the time you're going to get burned. All right, the diagnosis you will never document. So you will never document gastritis or gastroenteritis on a chart. You can say that you're suspecting that it's that, but that is not your final diagnosis. Your final diagnosis should always be the symptoms. So it could be nausea, vomiting, diarrhea. And if you're truly going to say that you think it's gastroenteritis, they should have vomiting and diarrhea. So it makes its way through the bowel. Diarrhea is the last part. They're going to initiate with vomiting, but that can mimic a lot of different things. So we don't want to pigeonhole this patient with a diagnosis of gastroenteritis. We want to make sure that we're diagnosing their symptoms. So traditionally we'll diagnose vomiting, or abdominal pain or diarrhea, but not the gastroenteritis or gastritis. We can say in our medical decision making that we're suspecting this. However, we should diagnose them with their symptoms. So they would be epigastric abdominal pain with vomiting. That's their diagnosis. The elderly patient with abdominal pain. So very interesting data here. So what is the mortality rate of an MI? So traditionally, a ST elevation MI is going to have a mortality rate of 8%. An elderly person with abdominal pain is going to have a mortality rate of 10%. So we get really excited about MI, ST elevation MIs, and we talk about balloon time. But look at this. The little old lady with constipation in room 12 is 2% more likely to die than your ST elevation MI with the whole crew in the room. So never blow off your older patient with abdominal pain. Abdominal pain out of proportion with exam. You'll hear this a lot. Pain out of proportion with exam. Like, what the heck does that mean? Basically means that the exam is benign, so you can push all over them. You don't make it worse, but they are writhing in pain. And so if the abdominal pain is out of proportion with exam, it makes it much more concerning. It makes it very concerning for a triple A. So mesenteric ischemia is also another one that can be pain out of proportion with exam. You're going to have your vasculopath, so your atrial fibrillator with atherosclerosis, and their lactate is going to be elevated because they are producing lactic acid from lack of oxygen, and they're performing fermentation. So always a low threshold to CT these patients, particularly the elderly patients. All right, so triple A, how is that going to present? It's going to be a variable presentation, but generally it's this excruciating back pain, abdominal pain with a component of syncope. So one thing that you'll hear about a triple A is that often they'll have a complaint like pain in the abdomen, but then they'll also have pain like in their toe. The thinking here is that the aorta is the only thing that connects the top to the bottom. So if they have chest pain or abdominal pain with a seemingly unrelated complaint, that is concerning for a triple A. We need to do an ultrasound. Anything greater than 2 centimeters, we should get some sort of a surgical consult. If it's greater than 5 centimeters, we definitely want to get a surgical consult sooner than later. And we don't want to hesitate to let the surgeon see them. These people die quick. All right, so let's get back here. So imaging by location. So let's think about what can happen at each location. So we've got the left upper quadrant. We've got the spleen, colon, left kidney, and the pancreas. So any pathology in these areas can elicit discomfort. Generally, this is going to be a CT. Left lumbar region or the left middle region, we've got the descending colon and left kidney. So you're talking about non-contrast CT. If we're concerned about diverticulitis, it's a contrast CT. The left inguinal region or iliac region, you got the descending colon and the sigmoid colon. CT with contrast or regular CT. The hypogastric region or the suprapubic region, urinary bladder, sigmoid colon, female reproductive organs. So that's either going to be an ultrasound or a CT. Umbilical region, so the umbilicus, parts of the small intestine, the intestine, and the duodenum. So we'd be thinking about bowel obstruction. So that's IV contrast, PO, IV contrast. Epigastric region, stomach, liver, pancreas, duodenum, spleen, and adrenals. So primarily we're worried about some sort of gastric pathology. So we can probably not do much imaging here. We may do a chest x-ray to look for free air under the diaphragm. We could also do a CT with contrast. The right upper quadrant liver, gallbladder, right kidney, small intestine. By far, this is where the right upper quadrant ultrasound is going to come in play. And then the right lumbar region, which is the gallbladder, liver, and right colon. This is also a right upper quadrant ultrasound. The quadrant 7 here, so the right iliac or right lower quadrant, we're thinking about appendicitis or inflammation of the cecum. So this is going to be a CT with contrast or an ultrasound. So in conclusion, what's your clinical gestalt? So if you have any doubt, get a surgical consult. Give the patient really good return to care precautions. So, if you're suspecting that it's gastroenteritis and it's early onset because they're vomiting, but you're still considering that there could be an appendicitis, you might want to tell them, based on your clinical presentation today and things that I've seen in the past, I feel like you're suffering from a gastroenteritis. However, a appendicitis can also present this way. So if you start to get focal abdominal pain, like in your right lower quadrant, and you're not able to hold down food and you start running a fever, you need to come back for reevaluation. So also we want to tell these people, hey, in 12 hours, if you're still this bad, come back and see us because we may need a further workup. We want to document a repeat exam. So you need to repeat exam the abdomen before the patient leaves, give them good return precautions. And then you want to document what you think and when you want them to return to their primary care physician. So that's the conclusion of abdominal pain. It's fast and furious. This video is really made to watch multiple times. I highly recommend that you watch this before you go into your ER rotation, as it will give you a good background and some good differentials to kind of think of and impress your attendings. I hope that you don't have any questions. If you do, give me an email. All right, good job.